Hi, everyone. I will get started, and then I'm sure we'll have a couple more people join. Welcome to today's Public Health Essentials for Health Department sessions focused on environmental health risks, responses, and resilience. I'm Christine Ganella, Executive Director of the Pennsylvania Public Health Association and Managing Director of Strategy Development with Public Health Management Corporation. Today's webinar is being hosted by the Pennsylvania Public Health Association and Public Health Management Corporation, with support from the Centers for Disease Control and Prevention Public Health Infrastructure Grant and the National Association of County and City Health Officials. The Pennsylvania Public Health Association is a state association of the American Public Health Association and seeks to advance health and all policies throughout the Commonwealth of Pennsylvania. Public Health Management Corporation represents the Public Health Institute of both Pennsylvania and Delaware, and builds healthier communities through partnerships with government, foundations, businesses, and community-based organizations. It fulfills its mission to improve the health of the community by providing outreach, health promotion, education, research planning, technical assistance, and direct service. Before we dig into our webinar, we're going to quickly go over some housekeeping. All participants will be muted throughout the presentation. We encourage participants to submit questions through the Q&A feature at the bottom of your screen. And a post-webinar survey will pop up at the end of the webinar. Please take a few minutes to complete the survey evaluating this live webinar. Your feedback is critical to the ongoing development of our webinar topics. So I'd like to welcome everyone to the Environmental Health Risks Response and Resilience webinar today. Our speakers are Dr. Ruth McDermott-Levy, and who is the professor and co-director for the Mid-Atlantic Center for Children's Health and the Environment, and Dr. Michelle Kelly, who is associate professor and co-director of the Mid-Atlantic Center for the Children's Health and the Environment. I'm going to pass the webinar over to Dr. Ruth McDermott-Levy and Dr. Michelle Kelly.
Welcome, everybody. I am, on behalf of Ruth and myself, I'm thrilled to have such a wide audience. I was checking out the chat there. It seems like we have covered most of the states, and I saw someone pop up there from Nigeria, so I'm thrilled to have such a wide audience today. Next slide. We acknowledge our funders and our support, which comes from the Centers for Disease Control and the Agency for Toxic Substance and Disease Registry, and our National Program Office, which is the Public Health Institute, which supports all of the pediatric environmental health specialty units. Next slide. So to start off with, we just want to sort of put some history, because I think it's always important to start with history and understand where we've come from. Why and what is a pediatric environmental health specialty unit? Two events occurred in the 1990s that highlighted the need for children's environmental health resources and education. One event happened in New Jersey where children and adults were exposed to mercury vapor from a converted industrial building. And what really sort of, not so much the exposure that caused the conversation about PEHSUs, but the fact that physicians and healthcare providers really failed to recognize, and they failed to ask the questions about, to identify the risks. So we were treating these kids and not contributing it to the exposure that they had. And then there were also several thousand people across 9 states that were seeking emergency medical care after their homes were illegally sprayed with an insecticide. Again, patient history and failed to identify or to link the insecticide exposure. So really it caused a delay in treatment and a delay in how we got our patients appropriately managed. And what was recognized was that we really need to do better in terms of educating providers and providing resources for frontline clinicians and families. So in 1998, the Agency for Toxic Substances and Disease Registry of the U.S. Department of Health and Human Services funded PEHSUs in Boston and Seattle. Next slide. Now there is a network, a national network of PEHSUs that cover all regions in the United States. Ruth and I represent, and Susan, who is on the call as well, represent the Region 3 PEHSU. But as you can see from the map, there are 10 PEHSUs across the United States that cover all U.S. regions. PEHSUs provide a resource for health professionals, school personnel, patients, communities, really, and for each other. We're in a collaborative network where we work together to address the issues that are brought to our attention, and to really support health professionals, to educate health professionals. We are not your first phone call for emergencies. That would be poison control or your emergency room, but we do provide education and support. So we have families reach out to us and say, you know, my child has an elevated lead level. What do I do about it? Or we have providers that reach out to us and say, you know, I'm caring for a child that was exposed to asbestos. What are my next steps? This is what I've done. What should I do next? And we provide some of that guidance. Next slide. The Mid-Atlantic Center for Children's Health and the Environment, which covers Region 3, is one of the 3 nurse-led PEHSUs in the United States. Our team includes a slew of environmental health experts, nurses, nurse practitioners, nurse midwives, public health experts. We have medical and toxicology consultants, and we service Pennsylvania, West Virginia, Virginia, Delaware, Maryland, and the District of Columbia. And I'm going to pass it over to Ruth.
Thank you so much, Michelle. I'm going to be talking about PFAS and extreme cold. It's kind of a funny combination. We talked with the planners of this and decided that they were kind of to discuss an emergent environmental issue such as PFAS and then a climate issue. And we came up with extreme cold, although we were talking earlier and we probably should have done wildfire smoke. But here we are. So the issue with PFAS, and I'm sure you've probably all heard about these forever chemicals that are out there. It is a group of over 14,000 chemicals that are in the PFAS family. And PFAS stands for per and polyfluoroalkyl substances. So it is a large group of chemicals. And the piece for those of you who loved organic chemistry, what makes them PFAS and what makes them resilient to heat, grease, and moisture is this fluoride or fluorine bond and this double oxygen and carbon bond. And so that is really difficult to break down, and that is why it's got the name Forever Chemicals. Next slide, please. So this is a photograph or an image of the PFAS family of chemicals. And of course, it's not all 14,000, but you can see like they're related and there's some similarities, and that's why they're in that group of family. And as I said, the resistance to the heat and grease and moisture is what makes them really something that industry really appreciates for thinking about, flammable, flame-resistant materials and, managing greasy situations, and then also thinking about things that, waterproofing things. So, they have been in existence for over 70 years, and now we're experiencing the problem with it. Next slide. So what the human impacts of these groups of chemicals Again, they are considered forever chemicals, so they last in the environment for a very long time. They do eventually break down, but it takes a long time for the breakdown. And that means it's the same thing in the human body. This actually is from, as you can see, the European Environmental Agency. So this is a global issue. It is not just an issue for the United States. But the solid lines are the high certainty. So looking at all the research related to PFAS, they found that those with the solid line, and I'm not going to read every single problem with it, is definitely related to PFAS exposure. The dotted lines are the areas that there's some low certainty. So they're keeping an eye on it and they're seeing, some relationship, but they're not entirely sure. So they're the things, again, that we may see this all change as research evolves. Next slide. So in 2022, the National Institutes of Medicine, Engineering, and Science published this document about PFAS. And what they did is they looked at all the science and the credibility of the science and determined, again, where there was enough evidence to say there's high probability that this is caused by PFAS, and then, like lower level of evidence. So what they found was a decrease in antibody response, which means that people, their immune system may not respond to exposures to things such as vaccines. And I'm going to talk about that in a little bit. But they found that in both adults and children. Dyslipidemia, which would mean elevated cholesterol, both in adults and children. And we typically don't see that in children. And then decreased infant and fetal growth. And Michelle is an expert in neonates and could talk to you probably quite a long time of how important it is that we have full development of the infant and the fetus for a full and healthy life. So that is another problem. And then also increased risk of kidney cancer. And I actually know someone who does have kidney cancer related to PFAS exposure. Next slide, please. So this is just a quick overview. This doesn't even touch the surface of the studies that have come out since the publication of the NESOM report. And you can see, again, we have issues with sperm motility and quality, so that's going to affect reproduction. Problems related to gestational hypertension and preeclampsia. So these are issues that can occur during pregnancy that can influence the outcome of both the mother and the fetus. Problems with decreased bone mineral density in children and young adults. And that can influence development of the bone and fractures, and then association with poor attention and poor executive functioning. So cognitive development and activity-related development and school success for children. And so these are things that we need to keep an eye on. But those of us in public health are really more about prevention, and we're going to get into that. So next slide, please. So we hear a lot about anti-vaxxers, and the true anti-vaxxer is the PFAS and the PFOA. And these are within the PFAS family. And what they have found is there's very high evidence that these do suppress antibody responses. And so we get animals with moderate level of response to vaccines, as well as humans. And so there's two problems with that. There's a risk then of zoonotic disease, and then also a risk for humans that have a vaccine and we think, it's going to work, and it may not work. And they found that with the COVID vaccine, but we're also monitoring children for their childhood vaccines that, that they are mounting the appropriate response so that they're protective. So these are things for us to worry about. Next slide, please. So you are going to get the slides, so I'm not going to read all this to you, but this is a nice reference if you want to look at specific, if people do get blood work done, and we'll talk about that, related to specific PFAS compounds. These are the things that we would expect to see. So these are the variations that we see related to those compounds. Next slide, please. So who's at risk? Well, one group that is at risk is certainly firefighters. Using Class B firefighting foam can be a problem. Also, the military that uses a lot of firefighting foam and other products that contain PFAS. And we've also found around airports where they, again, either for training or real events where there's firefighting foam. So people who work there in that environment, and then also if people live close to airports, they're finding that their water supply, especially if they rely on a well, it can be problematic. But the truth is our municipal water supply is not prepared to address these issues yet either. Next slide. So not only then are people in industry at risk, but we also find PFAS in consumer products. And the list is here. Non-stick cookware can, when it breaks down, then can add PFAS into your food, and then you would ingest that. Also, there's coatings on our takeaway food, such as pizza boxes or the fast food wraps. Again, it makes sense to use this coating because it doesn't get greasy, and it doesn't respond to moisture. It keeps things the way you intend it to be for the food. But if it can get into the food, then we ingest it. Also, we see it as in stain-resistant furniture and carpets, and also water repellent and stain-resistant clothing. And so, you think about how that might shed and cause a problem, especially for children related to the carpeting and furniture. We also see it in personal care products. It is in dental floss. It is in shampoo and cosmetics, especially those cosmetics that last a long time. There's a reason that lipstick stays on your lips for a long time. And so that's something to think about. And again, make good choices and share that with people. And then also, any kind of sealants. Nordic ski wax, a scientist that was studying PFAS actually found elevated PFAS in her community, and around her home, and started kind of figuring out where it was coming from. And it was the wax on cross-country skis. And then also our long-acting medications actually may have PFAS in them as well. So there are things to think about. Next slide, please. So because this is so long lasting, and it can, as I said, it can get into the waterways if it's used, out in industry, or if it's used as a firefighting foam. And so then it can get into the fish and the wildlife. They've also found it in the snow and air, and even in pine needles. So this is ubiquitous. This is, pretty much everywhere in the United States. And the NHANES study from 2014, there was a delay after COVID and for studying PFAS, but in 2014, they found that more than half of it was 85% of the people tested had some sort of PFAS. And then our U.S. Geological Survey found that 45% of our drinking water contained PFAS. So these are things to think about, and then we need to think about prevention. Next slide, please. So what do we do? Next slide. So thinking about the exposure pathways, it's typically by ingestion. So the highest place that you're going to find PFAS would be in drinking water. And then also, as I said, it can get into the food and from the food wrap, and then also get into our food from nonstick cookware. So ingestion is the primary way. We also can inhale it if it's in dust. Again, if you're around areas that may have used PFAS and then it gets into the dust. Here in the Northeast, it's been quite dry. So dust is a big issue right now for us. It is not typically or not well absorbed by the skin. And if you have issues with dust, or especially if you're using flame retardant or non-stick or stain resistant carpeting or furniture, you may find that that can kind of shed or peel, and then you can have dust in your home. So you want to make sure there's good hand washing and those things. And we'll get into that a little bit more. Next slide. So what happens to the PFAS once it gets into our body? It's primarily absorbed in the intestines and lungs, because if we ingest it or breathe it in, and as I said, typically not easily absorbed through the skin. It does bind with our serum protein, so we can test for it, and I'm going to talk about that in a little bit. And it also then binds with the liver, kidneys, and brain. And it is not easily metabolized. Again, this is long lasting. And if it is metabolized, it breaks down into other PFAS products. So of that 14,000 groups of chemicals that's in the family. Typically, it's excreted by the urine, but also it can be excreted also by defecation, menstruation, breastfeeding, or placental transfer. So that's really not the way we want it to go, but that's kind of how the body rids itself of it. Of the PFAS that we have tested for, and I'm going to show you where that is in the waterways and all, but of that group, it can last a few days to 8.5 years. So that's a really long time. And in some of the other PFAS, they can last as long as 35 years. We're not testing for them yet. So that's, again, a problem. But if we're being exposed continually, we have the half-life of 8.5 years for whatever I'm exposed to today. But if it goes on, for another year, we've got another, it just keeps going on. And so that, again, is a problem. And we need to look at how to reduce exposure. Next slide, please. So I'm from Pennsylvania, so I'm just going to, every state has its own rules, so I'm going to share our rules, and then I'll also talk about the states that do have the rules and those who don't. And so in Pennsylvania, actually, I just talked to the water guy today. These are the minimum contaminant levels that have been determined for Pennsylvania. And what I found out is Pennsylvania got tired of waiting for the federal government, and they determined their own levels for right now until that's all settled. So you can see it's just for PFOA and PFAS. So it's not all of those levels that we really need to be able to test for. And it also, and this would be the case across the country, would only apply to our public drinking water. That's the only place we can regulate water, and I'm sure you're all aware of that. So those people who have private wells need to do testing on their own. And I was actually talking to a woman in Virginia yesterday who needs to do that because of some agricultural things that are going on near her home. Next slide, please. So this is my water quality reading for PFAS. I pulled up my own. I live in Chester County, Pennsylvania. And so the good news for me is that it's ND, means not detected. So it is, of the PFAS that we test for, and it's only 5 of them, that it is not detected. But you see the numbers next to that. It actually means that there's 11 parts per trillion related to the perfluoroalkylic acid. So it's just that is not, I described it as an action level. He's like, no, it's not an action level. It is not the level that they would treat for. So there is a little bit in my water. Now, the nice thing about, I kind of dove into what was going on with my water. The nice thing is in my region, they just put in a filtration system. And it costs, I forgot how many millions of dollars it costs. But not every region has that, and not every region can afford that. I was really pleased to see that. Now, on this slide, and you will get, as I said, you'll get the slides. There's a link for the screening for PFAS levels in your blood. And so you can link on that. You're going to need your water quality readings for the last 2 years. And it asks you about your gender and a variety of things. Are you breastfeeding? A variety of things like that. And it estimates what your PFAS blood level might be. So if it's something you want to know or concerned about your risk, it can give you an estimate. It's not going to give you your blood level. They didn't draw the blood. But, it can let you know where you are. And if people are interested with you, who you work with, you can share that with them. But you may need to also help them get their water quality reading. Next slide. So these are the states, the dark blue states, the states that already have drinking water regulatory standards. And you can see it's like 9. So it is not enough. And so we need many more standards. So those of you who are not in the states that are dark blue, we all need to work to advocate for that and get stronger policies for our water. The nice thing is Delaware and Virginia, they have it pending. So hopefully that will change soon. And then the other, the aqua-ish color states have guidance levels. So these grayish states, those of you who are from these grayish states, you need to start addressing that to protect the health of your communities. Just a little aside, yes, you will get access. I just saw somebody else. You'll get the slides. If advocating is not something that you're comfortable with or you're not able to do in your role, join with an advocacy organization, because that's typically what I've done in the past, and they can help maneuver all this. So, and Safer States is a good place to start. So, but this is something that, you know, is going to be around for a very long time and we need to address. Next slide. Thank you. So, if people find that, that they have high levels of PFAS or concerned about PFAS in their homes, they can get a granulated activated carbon filter or reverse osmosis. These are very expensive, and so not everyone can do it. We're talking thousands of dollars. So they also then can get, if that is not an option, they can get a filter system, and there's just a picture of what one might look like, that they can use then for all their cooking and drinking, and that would certainly reduce the risk. Again, I always think of this a lot like what we tell people with risk of lead exposure. Wet mopping and wet dusting and vacuuming to reduce hand to mouth exposure, especially if there are children in the home. Really good hand washing people should do, again, if there's a risk. Well, we should do it anyway. And then also, if you look at your products and see the word fluoro in the ingredients, you want to avoid that, because that's an indication that it more than likely has PFAS. And then also, you know, for children, we primarily work with families with children. Make sure that they're not crawling or playing on PFAS treated carpets. And that's sometimes easier said than done. I've encouraged people to put down like a play mat that they know it doesn't have any of those PFAS chemicals that is safer for kids. Because it can get in the water, you want to check your advisories for fishing. And then back to the kids, if they are using pre-mixed baby formula, that to make sure that the water does not contain PFAS. So that may require using bottled water or, again, filtered water. The guidance right now is if people are or breastfeeding people are exposed to PFAS, that they should continue breastfeeding. They really need to talk to their provider about that, because you want to really make sure that we are identifying what is the risk for that person and that baby before they determine breastfeeding. So that would require a conversation, you know, either with the obstetrician or the pediatrician to make those decisions, or the nurse practitioner. We can, as I said, you can check for blood for certain PFAS chemicals, but it does not indicate when someone was exposed or if they'll be ill. And so that's another thing that requires a conversation with a provider. Most of us are saying it may not even be worth testing, because, again, it's not going to tell us a lot. But that, you know, talk to your provider about that. And then, again, we need to advocate for policies that protect people from this, but also policies that protect life cycles of all products. This, you know, got out in the environment because we weren't paying attention. And so we need to make sure that those regulations are in place from, you know, from the time it is created until it is discarded. Next slide, please. So some other tips of things that work. cookware options that I will help reduce PFAS exposure. Cast iron is great. It's my favorite. It makes wonderful omelets. And then also stainless steel. Again, stay away from the nonstick cookware, and then you don't have those problems. Next slide, please. Also, consider bringing your own containers when you're going out to eat, and it reduces waste, but you know then what is in those containers, and so it reduces your risk. And I actually am in a community that has reusable containers that you can take, like when you order something takeout or to go, you tell them that you're in this program, and they give you the container in a stainless steel container that I have to scan in when I go to take it, and then I have to return it and scan it back in. So it takes extra time, but again, I know my food is not being exposed to PFAS or anything else. I'm reducing waste. And so, you know, all of this kind of makes it all better for everybody else, but that takes time. So, but it's something to think about. How can we do things differently? Next slide. So we've heard a lot about microplastic. It is another environmental problem that another wicked problem that we need to address. And so the thing with that is, because microplastics is also ubiquitous, the PFAS can connect onto that. And so that can be a way we can either ingest it or breathe it in, or it can be part of that. And so, you know, these are problems that we need to really think about and how we can address this. Next slide. So that moves us to extreme cold, which is kind of a weird segue from after talking about that, but these are the topics we came up with. So, and it's been unseasonably warm in the Northeast, and I think around the rest of the country actually, but we do have the risk of having these extreme cold events. And what happens is we have the jet stream, and it's typically very strong. So the image on the left is, you know, a strong intact jet stream, which keeps the cold from the Arctic up in the northern regions. But when the Arctic is actually the area that is getting the warmest. And so with warm air in the Arctic, it makes the jet stream unstable, and it dips down or bends down into areas that are not used to extreme cold. The blizzards of 2014 in Boston is partially blamed on this. So that's one issue. And then also the issue with Texas that we saw extreme cold in Texas in 2021 was also a major issue for people who were not used to the cold. Boston was at least used to it, but not used to 5 feet of snow. Next slide. So this is the dates only go to 2014, but things are not that different in that this is mortality, a graph with mortality related to extreme cold. And what I want to point out in this slide is that we are having more deaths related to extreme cold, but those who have underlying conditions such as chronic illness, diabetes, obesity, cardiovascular disease, respiratory disease, are at greatest risk of death. So they're among the vulnerable people for us to think about. Next slide. So this is Texas on Valentine's Day. This is a 2021. We can see the winter storm warnings for the whole region, which is, I can't think of another word other than crazy. I mean, you know, we never see this in Texas. At the time, Dallas-Fort Worth Airport had a -2 degrees Fahrenheit. And the typical temperature for that area is average about 50 degrees. So this is significant. And so we're talking about people who are not accustomed to the cold, don't have clothes for the cold. You know, they don't have the layers that we're used to in the Northeast, and their homes are not insulated or prepared for the cold. So this was an extraordinarily challenging situation. There was loss of life. And it was attributed to climate change. Next slide. So things for us to think about is, of course, we can get some frostbite and hypothermia. We do get cardiac events, and this all can lead to death. We also can get, and many of you, I'm sure, planned for this when you're talking about extreme weather events. But again, thinking about those areas that are not accustomed to this, these are things that we need to keep on our radar and think about. Is we get increased accidents and injuries. People may be using machinery they're not accustomed to, snow blowers, all kinds of things. People may be shoveling snow and they're not used to it and don't know kind of how to pace themselves. And also they may be using generators that are gas run or diesel run, and we have problems with not only poor air quality in the area, but then carbon monoxide poisoning. So they're the individual risks that we need to worry about. Next slide. When we think regionally, and we saw this in Texas, it was a tax on the overall infrastructure. And so the energy grid could not handle the demand. And then there was disruption from down wires, from snow, and people not being prepared to manage the cold. So these are things that, again, we need to think about from a planning point of view of how to address that. Also, water pipes were broken or frozen, and so people could not get potable water. And then there was also disruptions in food getting to the region, or people not, being able to get out to get food themselves and not being able to get to healthcare emergency services. So, the areas that are not accustomed to this need to really think about how to plan for that. Next slide. This is just a slide just reminding us of who's vulnerable, and it's the same list that we see all the time. The one I do want to highlight, though, is for immigrants or people who don't speak the language. If people are new to the area, they actually may not even be able to read the sky and know which way to look for poor weather and those sort of things. So that is a group, and they may not be able to contact or know how to contact emergency services. So that is a group that really struggles during this, as well as everyone else that's on this list. But again, this is a group of people that we hear consistently. The extremes of age, the unhoused, low socioeconomic groups. Next slide. So what do we do about extreme cold? Next slide. The key thing, again, from a public health point of view, is that we really need to make sure that we're educating the public, because human actions really can make a difference in this. And we need to prepare now. We can't run out, and go, oh my goodness, what do we do with cold? It's the same, with us on the East Coast having to deal with wildfire smoke. We had to quickly, kind of backpedal of how to address that. But so we need to consider how to deal with extreme cold in advance, and then at real time share that information with people through the various sources of media, radio, TV, social media, and really push it out there as much as possible. It doesn't hurt also to prepare people of what might happen. So in these cold months, I love putting stuff on buses because they're riding around throughout the whole neighborhood. So that's another great way to get the information out. But also, of preparing them, make sure that they're aware of what might, have preparation for loss of power, how to effectively and safely use home generators. Think about maybe community heating sources, just like cooling centers, how we can address that for people who may not be able to manage generators or don't have those options. And also, if everybody's running a generator, it is really a terrible air quality issue. Thinking about, again, safe heating sources, educating people related to that, and then having people plan for, access to food and essential services and how that would be handled at the community level. Next slide. So I'm going to pass it. So I was kind of a Debbie Downer and gloom and doom. So we wanted to end things on a positive note. So I'm going to pass things off to my colleague, Michelle.
Thanks, Ruth. I'm just gonna back up a moment and recognize and acknowledge that because wearing the hat that I wear, I can't not do this. From a public health standpoint, making sure that the technology dependent and children with special healthcare needs are a priority in your communities related to extremes of weather or extremes of anything, right? The family that has a child that's ventilator dependent has backup plans, but when we get to these extreme colds or extreme weather events, their backup plans need backup plans. So just making sure that they are always on your radar and that there's always a community group that's checking in with them would be my push.
Thanks. That's
yeah. So when we focus on resilience or when we talk about resilience, resilience is one of those words that sometimes I feel like gets a negative rap, right? Because we expect everybody to be resilient. We expect everybody to have this, ability to bounce back. So when we have these conversations, I like to pause and remind all of us that you cannot pour from an empty cup. So if you have not restored your own, recharged your own battery, refilled your tank, you are unable to help others. And all of us on this call are in one way, shape, or form helping others. So we need to make sure that we take a step back. And one of the all of us have different ways for where and how we find that recharge. But nature is one of the best. Quite frankly, we know that spending time in nature, whatever you think your nature is, right? For me, it's the beach. But whatever it is, you need to be able to recharge yourself. And sometimes that even means writing yourself a prescription to do it, right? Not just making it be something that we'll get to. Next slide. Recovery and recharging is a skill, and it requires practice, and it requires a commitment, whether that is a personal commitment, whether that is a organizational commitment, to acknowledge how important recovery is for our employees, our staff, our communities, our families that we're serving. Overwork, is totally glorified by today's society, but overwork really ends up undermining productivity and the ability to be effective. So practice recovery for yourselves. Next slide. And given all of the stress, Ruth, and the reality that these chemicals are never going away from our bodies, the climate and environment that we are in at the moment can sometimes make us feel so overwhelmed and so how can I possibly make a difference? I am just one person, or I'm just one organization, or even if I fix it in my community, how do I make it better for the world, right? So we want to fix everything. And for me, the Daffodil Principle helps me remember that we can do great things by taking one step at a time, by making one change at a time. And together, all of those singular changes really can help breed resilience. If it's an institutional or organizational change, those changes will compound and make your work environment better. If it is a personal change or a personal step, Ruth's community is doing the takeout containers, right? Maybe that would work in your community, maybe that wouldn't, right? But whatever it is, commit to making one change at a time and then moving things forward. So at this point, I think we'll open it up to questions. There were I saw two questions in the Q&A. And there may be one or two in the chat as well. You're muted, Kristen.
Ruth and Michelle, thank you so much for the presentation today. We really appreciate the perspectives you shared on really such a critical public health issue. I wanted to maybe start in the chat so it doesn't get lost in there. There was a question about what impact does the EPA level have that was set in April of 2024. And it looks like Lorene had responded back, but wanted to give you both an opportunity to respond to that as well.
There, I was having a problem unmuting. So the EPA guidelines are, we have until 2027 to be able to institute them. So not every state is ready to do that. And so that's one of the issues is it depends on the state. I feel very fortunate that Pennsylvania jumped onto this, but so we don't know how long it's going to, what that impact is going to have, because some places haven't started yet. And I don't even know, it will be interesting to monitor or study the states that have started doing it and see, what changes we've seen in the water, and then what changes that we see in the health of people.
Wonderful. Thank you, Ruth. I'm going to switch over to the Q&A box. Ellie had shared a couple questions. I'm going to try and break it down for you. Ellie had asked, you said that our municipal water supplies are not prepared to deal with the issue of PFAS contamination. But what are your opinions on the new regulations implemented by the EPR for the NPDWR? If water distribution systems are above their MCLs, how can they combat those levels? And what are forms of treatment? So it's a lot.
Yeah, it is a lot. And I'm gonna say that I am not a water person. Like I don't, I call my water people to explain that. But you did ask my opinions on the new regulations. I think they're great, except as I said, this not all, they have till 2027, and not all states are there yet. And so that, that's the big issue. And again, I don't know how water treatment is done. I just know it happens. And so that's why I rely on the experts for that. So I'm sorry I can't give you more information. If someone does, please add to the chat. We'd appreciate it.
Yeah, and what we've done in the past when we have questions that we're not able to answer, we can do some digging around, and in a follow-up with the recording, are happy to provide additional information that we've been able to pull together. So let's go on to Kristen's question. Realizing that generators are decreased air quality, what are alternatives for people to stay in their home during a power outage?
I mean, anything that I'm going to say generates heat is going to be burning, right? So you're going to have, you can burn in a fireplace. You can have other heating sources that will burn, and products of combustion cause either, the smoke from wood fire or carbon monoxide. So that can be an issue. But, if we have an extreme event like we had in Texas, some of those heaters may be good if we have good ventilation. So that is one option. And then the other option for staying at home would just be layers and a lot of blankets, but it got so cold there that was not a good option. So what I'm saying is the communities need to look at that and look at how they can provide heat. It may mean moving people to other places, and that can be challenging too. Again, looking at all the snow. So that's things that need to be worked out.
Wonderful. Thank you. So Elizabeth asked, for young children exposed in utero, when can it be identified postpartum, and what sorts of treatments are available for developing infants ongoing through development?
Okay, so the children that are exposed in utero, sometimes we don't always know. Number one, but then as far as treatments, it's going to be identifying what the issue is. And so if it is an issue of cholesterol, they're going to identify that. If it's a developmental issue, they may use, what is it called? Michelle, help me out. The early intervention.
Early intervention.
Yeah.
The big take home is regular screening.
Right.
So screening for developmental milestones, early and appropriate screening for cholesterol and dyslipidemias. We're also, primary care guidelines say that we should be screening kids at 2 and between 9 and 12 for dyslipidemia. And quite frankly, the follow-through rates are really low on that. A lot of places don't get it done. So adhering to screening guidelines themselves is the first step, right? So that we may not be able to change the exposure, right? The exposure has happened, but we can manage the risk associated with the exposure. We cannot manage the risk associated with it unless we identify it. So health promotion and primary screening is really essential.
Wonderful. Thank you, both Ruth and Michelle. You mentioned using charcoal filters. Do these remove PFAS?
So for filters, you want to double check any filter that you would buy or purchase, what it removes. So not all of them remove PFAS. So you want to just double check, what it is saying on, your filter, whether you get a pitcher filter or the larger, system within your house. Just double check that that's what it removes.
Wonderful. Thank you. Are there guidelines for interpreting blood PFAS levels if those are taken?
Yeah, the NISM report has it's titled something like clinical guidelines for PFAS. They are in that report. I don't have those with me mainly because I was saying it's really critical that people talk to their provider, so you want to do that. But please look at that report. It's available online.
Wonderful. Thank you, Ruth. And then there are also solar generators. So I think this is a comment from Kathy. There are also solar generators that can produce electricity that could be deployed during a power outage. So just as another consideration for a resource if
thank you. That's a great point. Yep. Thank you very much.
Really
and
appreciate
then also, major battery operated ones as well, the big ones. So thank you. It's a great point.
Really appreciate that. So we're at 12:56. So we are getting close to the top of the hour. I want to thank both Ruth and Michelle again. Really just a phenomenal webinar. Lots of take-home points to consider, both professionally and personally. So thank you just for that thoughtful presentation. Before we close out for today, I just want to plug a webinar that we will be hosting on December 12th. This is the structural determinants of health. We will be joined by Erica Burrows-Girardi from County Health Rankings, as well as Joy An from the National Nurse-Led Care Consortium. So please, we'll pop the link in the chat. If you're able to join us, we would love to host you. And for those of you in Pennsylvania or beyond, if you're interested in getting involved with the Pennsylvania Public Health Association, please join us. The QR code will take you to all of our membership information. Please follow us on our social media handles below. Want to thank Ruth and Michelle again for your participation, and for everyone who joined us on today's webinar. Have a wonderful rest of your week and a safe holiday. And look forward to seeing everyone in December on our next webinar series. So take care. Bye-bye now.